right, before we get started today, just wanted to remind you that the evals are open now. So your lab eval is only open till Sunday. I don't know if it's midnight, it used to be 5 o'clock, I'm not sure. But and the lecture one became available on Monday and is available till the following Sunday, the 11th of December. So just wanted to encourage you to fill those out. Even if you're kind of, it was okay, didn't love it, didn't hate it, that is a data point for us. We do read those, and that student evals plays into whether professors get promotions sometimes, whether they get raises sometimes. So just encourage you to do that and make your voice known, give us some feedback. Also wanted to start with a few practice questions before we get going. From somebody complained to me yesterday, or having a discussion how to study for the final, and I said, well, especially study the pathogens. And somebody complained to me, but there's so many. I said, well, you gotta just keep reviewing them, right? Hopefully this stuff is interesting to you. I find it quite interesting. So just review. It's not, pathways and things that are complicated. So just keep going over it. Okay, I thought maybe this one was kind of on the easier side. I was kind of going through and trying to find questions from our old textbook. Which of the following bacteria produce one of the deadliest bacterial toxins known? So C. diff, that does make a toxin, not particularly deadly one. Mycobacterium doesn't produce any toxins. So that kind of narrows it down a little bit. Clostridium tetani is actually that tetanus neurotoxin. That's the most toxic, one of the most toxic things known. So that one, I'd throw that out there. How about this one? Again, a little terminology that may have been new to you. Skin lesions, characteristic of cutaneous anthrax. Remember, there's 3 ways we can get anthrax. We can ingest the spores, we can inhale the spores, we can get it in a cut. Okay. The skin lesions, remember that turns kind of black, a black scab, that's called an eschar. I don't know what this is. Question D there, somebody made that up maybe, or I don't know what it is, but I left that in there. All right, and lastly, give you a chance to read that a second. Okay, so this is a pathogen that also causes ear infections, sinusitis, also causes meningitis. The main thing it causes is pneumonia. All right, so that's Streptococcus pneumoniae. That vaccine, Prevnar 20, I just saw a commercial for that last night, conjugate vaccine. Okay, so again, just kind of keep reviewing. We're just adding pathogens as we go, so it gets a little bit more complicated as we go. We are kind of going in the order. We started with some gram-positive cocci, and then we went to gram-positive bacilli. Then we did an acid fast. That's not really gram-positive or gram-negative. And we started with our gram-negative cocci. All right, so the Neisseria, remember, there's a couple of different clinically interesting ones. The first one we started with here was Neisseria gonorrhoeae. Tend to present as pairs, diplococci. So let's see, last time we finished off with, we were thinking about gonorrhea, how it's passed, the transmission of it. What are the virulence factors that it has? Really, the main one here, that it certainly wouldn't be able to cause an infection without the fimbriae. We either call those appendages fimbriae or pili. remember way back when we talked about structures of bacteria, usually those short appendages that are important for attachment, when a cell has a whole bunch of them around the outside of a cell, we would call it fimbriae. But sometimes we call them pili, more often if the cell only has a couple, and usually if it's used as a conjugation, a means of conjugation for horizontal gene transfer. It's made out of the same protein, pilin. So sometimes we use those two terms interchangeably. Your book used the term fimbriae, so we'll go with that. Sometimes they're referred to as pili in the literature because some of the genes that encode them are called pil A, pil E, so on and so forth. So anyway, whichever you call them, really important for attachment to the epithelial cells of the genital tract. Okay, otherwise, I wouldn't be able to infect those cells. Okay, so there's two properties of those fimbriae that have made the organism extremely successful in outwitting our immune system, and that includes basically our inability to make a vaccine. So those two things, we describe the first, we call it antigenic variation. Okay, so the organism has the ability to actually change the protein combination or to change the structure of those pili. Okay, so the pili are the most antigenic thing. It's the first thing that our immune system notices, again, because it's protein, it's a complex molecule, and it's on the outside of the cell. So when that antigenic variation, that just means, again, that the composition of the fimbrial proteins changes. And there are other organisms or even viruses that can do antigenic variation. HIV does it, influenza virus does it, COVID does it, but those are all viruses, and they tend to do that over kind of long periods of time, over months. That's why we have to keep changing our influenza vaccine, because the viruses change. And it's actually a quite complicated mechanism. It's not just kind of random mutation. The organism has a specific way to very quickly vary those antigens for gonorrhea. How quick is it? It will change those antigens like weekly. So, once, remember, it takes about a week, 7 days, 10 days for us to make antibodies for a specific antigen. And once we do that, they're not good anymore because the composition has changed. So again, gonorrhea is that Neisseria gonorrhea is exceptionally good at doing that very quickly. We'll say, so antibodies produced no longer recognize the fimbriae. Okay. So that's really the main reason that people can get gonorrhea over and over and over again. And that's why we don't have a vaccine, because again, it's just so antigenically diverse. Another interesting thing that this organism does is what's called phase variation. And that just means that the expression of the fimbriae can be turned on or off. In other words, the fimbriae can detach. All right, so the analogy that I like here is if you're being chased by a polar bear, right? Imagine the scenario. You would maybe take off your hat and throw it down so the polar bear would maybe stop to smell the hat, right? So this is exactly the same thing. right? The organisms can detach their fimbriae so that the antibodies we make will stick to that, you know, instead of the organism, and, you know, maybe agglutinating those cells together. So the antibodies are not going to be helpful to, you know, do the agglutination or to, you know, keep the fimbriae from attaching. Okay, it follows the fimbriae off somewhere. Okay, so two interesting things again that help make the Neisseria gonorrhoeae successful. Another enzyme that it can secrete outside of the cell has kind of a boring name, a protease, but that enzyme is going to act on IgA. And remember where we find most IgA, it's most prevalent on the mucous membranes. Okay, so the primary antibody found on mucous membranes. So, you know, it's an arms race, right? We make the antibodies, and they make something. The organism makes something else to try to overcome that. In addition, it has a little bit different variety of lipopolysaccharide. Remember, that's on the outer membrane. It's a gram-negative. It's called lipooligosaccharide. It just means it has a little bit, we'll call it a variation of LPS. It has a little shorter polysaccharide, a little shorter sugar chain there. So we call it lipooligosaccharide. But it's still going to be, it's still going to have that endotoxin, that lipid A, as part of it, that's going to be responsible for causing inflammation in the host, fever, as well as some inappropriate blood clotting. And maybe the effect of that is a little bit more prevalent in the Neisseria meningitidis, but that endotoxin will cause blood to clot in some places where it shouldn't be. And then when all those clotting factors of the blood are kind of used where they shouldn't be, then maybe other parts of the body, the blood isn't clotting like it should be. So we get kind of, again, inappropriate clotting there. Okay. All right, so let's look at what the disease looks like, the symptoms. Sorry about the graphic picture there. Symptoms are different in males and females because the anatomy is different. But typically, after an incubation phase of maybe 2 to 7 days, so let's say 2 to 7 days after exposure, so after a sexual intercourse, where there's no symptoms, remember incubation phases, no symptoms, then males typically will start having symptoms. And your book kind of downplays that a little bit. It says that in males, a lot of times they don't have symptoms. That's not what I've read from other sources. But I have read that typically males do have symptoms, and it really hurts. So burning while urinating, I've heard it described as peeing fire, pus-filled discharge. Okay, it's very painful. So when males experience that, they typically go to the doctor and have it treated. Luckily, gonorrhea is still quite treatable. So they get some antibiotics and they get rid of it. Maybe if those symptoms are ignored, or you know, in some cases, if males don't have symptoms, then that doesn't mean that there's not any damage being done. Sometimes there gets to be so much inflammation in the epididymis or the prostate that can eventually cause infertility. And this organism also has the potential to disseminate throughout the body and cause all kinds of crazy symptoms that you wouldn't associate with gonorrhea, things like arthritis, let's see, skin rashes, endocarditis. That's, remember, inflammation of the heart valves. Again, something good to be treated. Females, about 50%, at least 50% of the time, don't have symptoms at all. More likely to be asymptomatic in females. And when females do have symptoms, sometimes that will mimic a urinary tract infection or a vaginal yeast infection. So they may try to treat what they think is a yeast infection themselves. Again, just because there's no symptoms doesn't mean the organism's not doing harm. More serious complications include pelvic inflammatory disease. So if the organism moves up into the uterus, then it can cause, this PID is basically just inflammation of the uterus. And other organisms can cause PID as well. Chlamydia, for example, can cause that. Inflammation of the uterus, so fever, abdominal pain, inflammation, okay, and that can lead to some scarring of the fallopian tubes, which increase the chances that someone would have an ectopic pregnancy. So that's when a fertilized egg implants outside of the uterus instead of inside of the uterus. So that can lead to infertility. Okay. So not something that you want to ignore, not something that's likely to go away on its own. Incidence is rising, unfortunately. Let's see, let me write in, let's see, are these the most, I've got some other numbers that I can share with you. But this is probably, by best estimates, the second most common sexually transmitted disease. I think I mentioned that last time. Chlamydia is usually the most common, but those two infections sometimes will go hand in hand. This is a reportable disease. So if you go to the doctor and get treated, the doctor has to report that to the CDC, which helps us have an idea of the numbers. But again, when sometimes people don't have symptoms for a long period of time, it's probably underreported. Incidence peaked here early 80s. That's right before AIDS came on the scene. So we have, we saw a downfall in cases because people didn't want to get AIDS and perhaps were practicing safer sex after that. I think now we're having a little bit of an upturn again. So in 2009, we had 300,000 cases in the US. 2019, in 10 years, we've doubled. So I think people aren't as afraid of AIDS as what they used to be. Also, one article I read suggested that it's so easy for people to find sexual partners now with all the dating apps that are out there. So who knows, maybe that contributes to it as well. Worldwide, 300 million cases 30 million cases worldwide in 2020. So the most common age group, most of you fall in that age group, so I thought it was important to talk about. Again, I guess that's just the age where people are more likely to have more sexual partners. So again, risk goes up the more sexual partners you have. The good news is, like I mentioned before, it is very treatable for now. I'm going to show you this little animation, this 2 or 3 minute animation put out by the CDC that talks about treatment. But for now, ceftriaxone, it's a cephalosporin. It's one of the later generation ones that has to be injected. That's what's recommended right now, but we have changed quite a bit over the years. There are some areas of the world where there are strains surfacing that are resistant to everything that we have. So they're focusing on prevention, abstinence, monogamy, safe sex. Okay, so let me see if I can bring this video up. I tried the sound before class. and it worked, but I had trouble getting it to open in Safari. Come on. Oh, there it goes. Okay. All right. So again, this is just a couple minutes long.
Gonorrhea is a major public health concern in the United States. More than 1 million new infections occur each year, but because many people don't have symptoms, fewer than half are detected and reported to CDC. Untreated gonorrhea can cause serious health problems. It can increase the risk of a life-threatening ectopic pregnancy, cause conditions that can lead to infertility, and increase a person's risk of getting or giving HIV. Medication to treat gonorrhea has been around for decades, but the bacteria has grown resistant to nearly every drug ever used to treat it. In the 1980s, resistance to penicillin and tetracycline grows, and they are no longer recommended to treat gonorrhea. Fluoroquinolones are the leading drugs to treat gonorrhea in the 1990s, but the bacteria was adapting to the drugs. CDC modifies treatment for much of the next decade to keep pace with resistance. In 2000, the drug is no longer recommended to treat people infected in Asia or the Pacific Islands. By 2002, this recommendation extends to California, and then in 2004, to men who have sex with men throughout the United States. By 2007, widespread fluoroquinolone resistance leaves only one class of antibiotics, cephalosporins, to treat the infection. In 2010, CDC recommends adding a second drug, either azithromycin or doxycycline, to the treatment regimen to protect cephalosporins from resistance. But just 2 years later, in 2012, CDC must update treatment recommendations again when data suggests the oral cephalosporin, cefixime, is becoming less effective at treating gonorrhea. As of 2020, CDC no longer recommends azithromycin due to emerging resistance that could threaten its ability to treat other common infections. Gonorrhea is becoming harder and harder to treat. Today, a single injection of the cephalosporin, ceftriaxone, is essentially all that stands between us and untreatable gonorrhea. Our last treatment option won't last forever. A difficult-to-treat strain of gonorrhea has been reported in the U.S., and broader surveillance shows half of all infections are resistant to at least one antibiotic. The U.S. hasn't seen a treatment failure with the recommended treatment, but drug resistance is rising, and the pipeline for new drugs isn't keeping up. Prevention, testing, and effective treatment are needed now more than ever. We must keep drug-resistant gonorrhea as a leading priority. Learn more at cdc.gov.
All right, so just to highlight, let me turn that back. That, this was really considered the #1 health emergency, drug resistance to, or resistance to antibiotics before the pandemic. And that hasn't gone away. We've had, COVID to worry about too. But I thought that was interesting that, we talked about how oftentimes we'll use 2 antibiotics to treat an infection to try to slow down resistance. In this case, they've taken away one of those antibiotics because they want to make sure they save azithromycin to treat, like ear infections and run-of-the-mill childhood infections. So I thought that was interesting, but a lot of surveillance that goes on to try to keep ahead of this. So maybe it's better to try and prevent gonorrhea in the first place. Unfortunately, we can't do that with a vaccine. We don't have a vaccine due to that antigenic variation. We'll see that we actually do have a vaccine to a similar organism, Neisseria meningitidis, But that organism has a capsule. Okay, there's no capsule for Neisseria gonorrhoeae, even to make a vaccine too. So, all right, questions, comments before we move on? All right, so the other clinically interesting Neisseria, remember these are gram-negative cocci, is the Neisseria meningitidis. Okay, and this is, I've been trying to point out where you can find these in OpenStax 25.2b. So chapter 25 is infections of the central nervous system. And B is gram-negative bacterial infections of the central nervous system. So there's a few homework questions there. This organism, like Neisseria gonorrhoeae, passed around between humans, okay, not zoonotic. Surprisingly, 10 to 20% of us are carriers. Okay, so that just means we carry the organism. It's probably replicating a little bit in our upper respiratory tract. For reasons that we don't understand, maybe it's not replicating enough. It doesn't necessarily make us sick. But sometimes that normal microbiota, for reasons that we don't understand, will invade the bloodstream and then target the meninges, which there's actually 3 different membranes that cover our brain and spinal cord. Okay, so transmission, droplet spread. So that's the big droplets, not the droplet nuclei that we talked about. Mycobacteriums can spread in. So it takes very close contact to be infected with a large enough dose, usually that will cause disease. Typically sneezing, being near someone that's sneezing or coughing, or sharing some kind of fomite like drinking glasses. Some of the outbreaks at colleges have been traced back to parties where people were sharing drinking glasses. Okay, so again, it affects the meninges, lining of the brain and spinal cord, and it causes an infection known as meningococcal meningitis. So we talked about other organisms that can cause meningitis, like strep pneumoniae, Haemophilus influenza. There are viral means of meningitis. There are fungal causation of meningitis. Viral meningitis typically isn't as serious because we don't get the toxin production like we do from bacteria. So early symptoms, things like fever, sore throat, nausea. Those symptoms don't alert you that you're dealing with anything life-threatening. The 2 kind of red flags, early symptoms, stiff neck and headache. Okay, those are the 2 that really kind of stand out. And not just a little headache, but like the worst headache you've ever had in your life. Okay, along with the stiff neck, that means that either you or whatever, the child that you're watching needs to be taken to the emergency room right away, because this is a very fast acting infection. If the doctor suspects meningitis, they will do a lumbar punch to test the cerebral spinal fluid, just to double check, but they'll probably start on antibiotics right away, because the infection does move very fast. As it progresses, this organism actually will start to release its outer membrane. It actually starts releasing endotoxin. So we've talked about how typically gram-negative organisms don't release that lipid A part of their outer membrane unless they're dividing a little bit, or if they die and that outer membrane starts to break down, the whole cell wall starts to break down. So this organism is really unique. While it's alive, it starts to shed that outer membrane, and we call that process blebbing. Okay, so it's releasing maybe 100 to 1,000 times more endotoxin than a typical gram-negative would, and it's more toxic. Okay, so that overwhelming release of endotoxin causes an overwhelming inflammation. Okay, very quickly, like within hours of the onset of the infections, patients might seeing petechiae. That's a rash that starts out red and then it turns purple and then it turns black. Okay, black spots on the skin caused by broken capillaries. Those petechiae can merge and merge into large areas of necrotic tissue, like this hand of a baby will likely have to be amputated. Again, the inflammation can cause the blood pressure to go way down and cause the patient to go into shock. All the organs start to shut down. High fevers, delirium, cardiac arrest, coma before death. Maybe what I've read, maybe a 10 to 20% mortality associated with meningococcal meningitis. And of those that survive, maybe 10 to 20% are left with some life-altering disability, like brain damage, blindness, deafness, amputation of limbs. So it's certainly something that we want to avoid if at all possible. So who's at risk? Anybody can get this. It's a true pathogen, but there are some people that are a little bit more likely. Young children, especially kids less than a year old. This is one of those that the capsule of this organism is one of those T-independent antigens. So younger children have less of a response to it, although adults apparently don't have a very quick response either. One age group where we see a lot of outbreaks, young adults. So teenagers, young adults, again, college campuses have been a spot of lots of outbreaks in recent years. It's very rare. It's a very rare infection. We will talk more about that. But occasionally somebody will get meningococcal meningitis a second time. And then doctors will start to see, well, is there something wrong with this person's immunity? And they usually find a complement deficiency. So we think complement activation is really important to fight this infection. Also, individuals without spleens, they are just a little bit more at risk to any bacterial infection, and kind of a catch-all, anybody that's immunosuppressed. Also, interestingly enough, there's this meningitis belt in sub-Saharan Africa, where incidence of meningococcal meningitis is much higher. They're not really sure why that is. You could blame the climate, dry climate perhaps, because the cases are seasonal. There are a lot more cases during the dry season, which is like December to June, I think I read. Put that together with kind of lower socioeconomic status, poor living conditions, poor nutritional status, and apparently that's may help explain why we have higher incidence there. This is a nice chart that just shows incidence by age recently, last 10 years or so. So, you know, young children, we got probably the highest incidence there. Incidence rises again with older adults just because immunity wanes as we get older. But there's this other blip, this young adult range, and whether it's just, you know, that age of people coming together more frequently, it's not really clear. Incidence in the US, in the last 50 years or so, it is very low right now. So again, a very serious infection, but also a very rare one. I believe the vaccine came out, the first vaccine that we had came out in the late 70s. So that probably, explains why, we've had, peaks and valleys, but explains how overall the incidence is getting lower. Okay. All right. So I already mentioned the endotoxin as a virulence factor. Pretty much other ones similar to Neisseria gonorrhoeae. It's got fimbriae, pili, of course, that are going to have adhesins specific for the meninges. Okay, not the genital tract, but the meninges. And unlike Neisseria gonorrhoeae, it makes a capsule. Okay, so that has an anti-phagocytic role. And also it helps the organism avoid complement. Okay, I don't really know what the structure of that, but perhaps complement can't as easily act as an opsonin. I'm guessing there. Okay, there's 5. Oh, so there's 5 main serotypes. There's 12 known to exist, but there's 5 that are the most famous, and those are named the A, B, C, Y, and W serotypes. Okay, 90% of disease is caused by one of those 5 serotypes of the capsule. Okay. Some recent serotypes. So we'll get to this in a minute. The vaccine includes the A, the C, the Y, and the W. Now, unfortunately, some of the recent serotypes have been due to an organism with a type B capsule. It was a little bit, I think we had to go about making a vaccine a little bit differently because of the B subtype. So now we have a separate vaccine for the B serotype, but it's so rare that, do we give it to everybody or not? That's the question. But again, some of the outbreaks lately at college campuses have been to that B serotype. So treatment and vaccine, what's recommended right now is a cephalosporin. Remember, the later generation cephalosporins are able to cross that blood-brain barrier, give the patient anti-inflammatories to try to counteract the endotoxin release. And if somebody is known to be exposed, then they'll take antibiotics just to try to ward it off, again, because it is so serious. Okay, so the vaccine, we're calling this something a little bit different than we used to. It's called Neisseria. Okay, so you can see it right there. Quadrivalent, meaning there's 4 different types of that capsule that are covered. And it is a conjugate, so meningococcal conjugate vaccine. So in other words, those polysaccharides from the capsule, they're not very antigenic, so they've attached it to some kind of a protein carrier to make our immune system notice it better. And like I said, we have a separate vaccine that's just a meningococcal B vaccine. You see commercials for that every once in a while. And again, do you vaccinate people if there's only going to be 10 cases in the whole country a year? It's one of those tough questions. So typically people are given the vaccine when they're around age 11 or 12. and then ideally get a booster maybe about the time they graduate high school, maybe before they leave home. So if this is something that babies get, why aren't we giving this to babies? The problem is it doesn't work in babies. So, you know, I don't know if any other formulation is in the works, but that's why we don't give it till later on. All right, any questions about meningitis, gonorrhea? Before we move on, okay. Oh, I was going to mention, when I searched before class, you know, recent outbreaks of meningococcal meningitis, they're actually, like I said, you usually hear about these at college campuses, but right now there's a pretty big outbreak going on in Florida among gay and bisexual men. Okay, 26 cases and 7 deaths. So it's not anything, this is not sexually transmitted, but it's just a population, I guess, that's in close contact with each other. Question? Yeah, so what causes the black of the necrosis when you get the petechiae? I think, I mean, capillaries are bursting. You know, that's a good question. Necrosis just means death of tissue. So if the tissue, yeah, it does look like it's burnt, but I don't think that has anything to do with it. I think it's probably just not getting blood supply. Yeah, so good. All right, so we'll move on. This is our last bacterial pathogen that I think we'll cover. Bordetella pertussis. Okay, that's the causative agent of whooping cough, sometimes called pertussis. This is a gram-negative organism, right? And if you see from this picture, it doesn't really look like a rod shape, doesn't really look like a true round cell. So indeed, we refer to it as a coccobacillus. Okay, kind of halfway between a rod and a cockeye. Another organism that's considered non-motile, no flagella, like the Neisseria, very considered fastidious. So it's difficult to grow this organism in the lab, has to have certain growth media. I know that when you test somebody for whooping cough, that test has to be really quickly transmitted to the lab to test it right away. Otherwise, the organism doesn't survive. So it's just hard to grow in the lab. And it's a strict anaerobe. So this organism only lives in places in our body that has easy access to oxygen, so respiratory tract. And humans are the only host. So there is a Bordetella bacterium that causes a coughing disease in dogs. They call it kennel cough. But humans can't get kennel cough, and dogs can't get whooping cough from humans. So I think it doesn't cross the species barrier. Okay. So humans are the only known host. Humans can also be carriers. So kind of like Neisseria meningitidis, we can have it as our normal microbiota in our upper respiratory tract and not be sick ourselves, but have the potential to pass that on to a baby. So that's why we recommend that pregnant women get vaccinated, and anybody that's taking care of babies gets vaccinated. Okay. All right, so the stages of pertussis disease are interesting. And we have special names for those stages. We don't just stick with incubation and prodromal and illness. We have special names for them when somebody is going through the disease. So incubation stage, remember, no symptoms. So after somebody is exposed, maybe 7 to 10 days, they don't have any symptoms. And then they start the catarrhal stage. Okay, catarrhal, that means inflammation of mucous membranes. Okay, and that's just a special name for the prodromal stage. So usually prodromal is kind of generalized symptoms. So in this case we have cold-like symptoms. So runny nose, maybe a little tiredness, maybe a little coughing, but not enough to make people usually stay home. And that's for this infection, it's the most infectious time, which is kind of unusual. So here we show catarrhal stage again. Usually it's the illness when the people are the sickest, they have the most organisms that are multiplying, but so it's a little bit unusual here. And then people enter what we typically would call the illness phase, the paroxysmal stage. If somebody has a paroxysm, a paroxysm, that's a violent fit. Okay, so this is where you see the hard coughing. There's some virulence factors that causes the body to produce like way too much mucus. So that makes it harder for people to cough it out. That hard cough, it can be so hard that it will break ribs. It can make people vomit as a result of it. And this is where you characteristically hear that whooping noise in young children. Typically adults, when they get whooping cough, you don't hear the whoops. Let's see if I can get this to come up. The whooping sound. Okay, it's not working for me. But there's a little recording. If you hit that little megaphone there, listen to that sometime. That whoop sound happens after the cough when the kids are trying to get air. So that kind of a noise. It's really like, after a while, like just shut that off. I can't listen to that anymore. It's heartbreaking. In young children, especially babies, that can lead to respiratory collapse and death. So again, most serious in young children, can even cause cyanosis, kind of a bluish tinge to the skin. It's been called the 100-day cough. So maybe, coughing 3 to 4 weeks, as many as 100 days. So 3 months even. So it's a cough that goes on and on and on, reaching into the convalescence period as well. And because the cilia of the respiratory tract is impaired a little bit, then that opens the host up to likely get some secondary infections like bronchitis or influenza or pneumonia, something like that. So that's what the illness looks like. Luckily, it's pretty rare. Droplet spread, so you have to be in really close contact with somebody. Okay, this is not airborne. Okay, so remember, the Mycobacterium tuberculosis, TB, was our airborne infection. After somebody inhales it, then it colonizes the trachea and the bronchi. This tends to go in kind of peaks and valleys. Our last really high year, in 2012, we had 48,000 cases in the US. I had some numbers about, where did I write that? I can't find, I had more recent numbers than that. I think we'll start with that next time. I'll find my numbers, we'll finish pertussis, and then we'll get into herpes virus. So have a good day.